Hello everyone and welcome. This is Joe Minardi, the guy who sleeps with an ultrasound in his bed at night. And welcome to the point of care ultrasound section of the surgical specialties prep elective. We're going to go through some applications and some clinical integration of how you might use some of these in clinical practice. Not going to spend a lot of time on basic anatomy and basic technique because we hope, one, a lot of that is review and hopefully you'll remember it once we start practicing a little bit. And two, for technique, we want to mostly focus on practicing that in the hands-on lab sessions, so I'm not going to talk a lot about that. I'm going to review some of the pathologic findings and some of the clinical decision-making for some of these applications to, again, supplement what we're going to do in the lab sessions. So the first one we're going to go through is we're going to talk about the FAST exam. And if you do any kind of surgical internship, the FAST exam is going to come up. It's going to be useful for you, and hopefully I can introduce you to how to use it clinically, and I'll give some of the evidence along with some of my opinions on how you can use this. And even if you're not in a general surgical subspecialty, if you're like an OB-GYN or something like that, the FAST exam has relevance beyond trauma and looking for free fluid and causes of shock. So we'll allude to that a little bit as well. So first off, we'll just start with a couple of cases. So this first one is an 18-year-old who was in an MBC, hit the guardrail, has abdominal pain. And when they first come in, their vital signs look pretty good. And here are some components from their FAST exam. We'll take a look at those. And then, so we can see here some of the findings. There's nothing really super specific here. We see this looks like the right kidney, and that's probably the liver. There, maybe something catches your eye there, but it's really hard to be definitive, especially in this single shot. Here's on the left side. Nothing super obvious. Again, there are a couple little subtle things that your eye might pick up, but nothing here that you would call based on these singular images. But then as we extend, as I recommend we do for every single FAST exam, down below the kidneys a little bit into the paracolic gutters, we see lots of marked free fluid in this patient's abdomen. So think about how that might influence how you care for this patient, your decision making, and how that might play a role in deciding who goes to CT scan first when you have this department full of 4 or 5 or 6 trauma patients and stroke patients all at the same time. So as I alluded to, we should be looking in the paracolic gutter for any patient where we're worried about intra-abdominal bleeding, and really what you do is just slide below the kidneys, fan to the ceiling, and you should be there. And this is our second case. This is a 36-year-old who fell from a ladder, has left-sided chest pain. And again, probably some subtle findings. These aren't nice crisp lines here, but it's really tough to make a definitive call with that single image. And here's our third case where this 20-year-old female fell from a window. Again, pretty stable vital signs. She's intoxicated, so some of the history and exam is a little bit limited. Our first look here, that's the edge of the bladder. And we don't see any obvious free fluid in there, but then as we fan all the way up and we actually get into where the pouch of Douglas is, or the recto-uterine pouch, we see a fair amount of free fluid in this patient's pelvis. So then we have to be suspicious of intra-abdominal bleeding once again. Here's another patient who came in after a motor vehicle crash. These are all real cases, by the way. Stable vital signs, but we see this is a pretty obvious clear-cut Morrison's pouch free fluid example. And we'll talk about some of the implications of what does that mean in a stable patient or versus the unstable patient. And in this case, next case, number 5, we've got a 72-year-old female who's been in a motor vehicle crash, a little hypotensive, normal heart rate, but breath sounds are diminished on the left. So one might think, well, let's just put in a chest tube. They've got shock, diminished breath sounds, it's probably tension pneumothorax. But when we look at ultrasound, we see nice sliding here on both sides, so maybe we should kind of step back and think about what else might be going on. And when this patient gets their x-ray, what we see here is the reason for their diminished breath sounds are their diaphragmatic disruption, and they have valve in their chest. So that's the reason for the diminished breath sounds and not a pneumothorax. So instead of placing a chest tube into their descending colon, we're able to hold off and manage the patient and get more definitive workup. Next case, 17-year-old who rolled their bicycle, got a little abdominal tenderness but normal vital signs. We go ahead and do a FAST exam and we can note some abnormalities. Maybe we see this liver kind of changes echogenicity here, it gets brighter. There's some brighter white than we would normally see in the liver here, so maybe that's a clue that this patient has more going on than just some mild belly contusion and maybe needs further workup, further attention. And if you're maybe in an outside facility, you would think about how are you going to triage resources and manage getting this patient to more definitive care. So we're going to go through the indications, we're going to practice basic images in our hands-on session, so I'm not going to beat that to death. Quick reminders about normal anatomy, but we're going to look a lot more at some of the pathologic findings, pitfalls, and we'll spend a significant amount on decision making because, again, the hands-on practice, the anatomy, the technique, we want to get that all in our hands-on sessions. So a little bit about why we would do the FAST exam. If you think about trauma, when your patient kind of rolls into the trauma bay, the things you have at your disposal are history and physical, maybe a DPL, not done a whole lot anymore. The FAST can add to that history and physical exam at the bedside. It's rapid, we can repeat it, there's no radiation, contrast, it's low cost. I don't think it's reasonable to compare it to CT scans. CT scans are great tools and they can tell us a lot of information, but it's not a bedside tool and it can't be repeated and it has costs and downsides associated with it. I'm not saying a FAST replaces a CT scan, I'm saying FAST enhances our history and our physical exam. And just as a note, we all know we do too many CT scans. If you look at some of the literature, our positive rate of CT scans in traumas is under 10%, so we're really swinging wildly at CT scans and we're not connecting with that fastball very often. And so we need to find more ways and initiatives to maybe cut down, maybe better risk stratify some of these patients and be a little more selective with our CT scans. So when we talk about the FAST exam, it's important to realize don't overstretch its capabilities. It's meant to make 4 diagnoses: pneumothorax, hemothorax, hemopericardium, and hemoperitoneum. So air in the chest, blood around the heart, blood in the abdomen. Those are the 4 diagnoses it's meant to make. When you do more than that, you're stretching its capabilities. Now we will talk about some findings and subtleties that will go a little bit beyond these diagnoses, but remember, these are rule-ins. You're never ruling out some of these parenchymal injuries that we'll talk about a little bit. Who gets a FAST? So anybody with multi-trauma. And you may hear some debate or some controversy. Some of this is my opinion, although there is evidence to back up some of the statements that I'm going to make. Adds to the history and physical. Make it part of the primary survey. Make these 4 diagnoses as we talked about. And let's talk about the stable versus the unstable patient. So it has the most crucial role in the unstable patient because it's going to maybe guide some of our immediate decision making. Whether we need to place a chest tube, do a pericardiocentesis, or maybe even open the chest, depending on your setting and your resources, do a thoracotomy, or get the patient upstairs quickly for a laparotomy. So these are critical decisions, time sensitive, and the FAST can help us quickly decide if these need to be done right away or do we have time to do other workup and resuscitation. Now in the stable patient, again, maybe a little bit more controversial, but I'm going to make my case to you why I think even in the stable patients, the FAST exam has an important role and can help us. It can help us in low resource settings where we may be working, but even in busy trauma centers like where we work, the FAST exam can help us tailor our decisions and triage who gets what resources when and how fast. If we see blood in their abdomen or we see a pneumothorax, then we know that information right up front and we know it at the bedside. We can get a baseline, so if we want to do serial FAST exams and follow a patient, especially maybe a pediatric patient or a pregnant patient, and be selective in our CTs, this can help us in that role as well. When we have multiple trauma patients and they all need to go to CT scan, maybe findings on the FAST exam can help us decide who goes first or who needs that extra nurse or the cooler full of blood to go with them to CT scan. FAST exam can help us tailor those decisions. So people like to talk about it being an operator-dependent or a patient-dependent modality. That's true of everything in medicine, so those are just excuses. I could say taking a history is operator-dependent. Get good at taking a history, get good at doing the FAST exam, eliminate excuses like this. Some other limitations: we don't know how big the pneumothorax is if we find one, so we have to incorporate that with the rest of the clinical data. We're not going to reliably diagnose retroperitoneal injuries and parenchymal injuries, although we'll look at some of those. Remember, we can't rule those out with the FAST exam. So those are some of the limitations, and as long as we know that going in, we know the test characteristics, we can apply it to our patients appropriately. A couple basic reminders we're going to go through and then talk a lot more about just how to use the information that we get. All right, so talking about ultrasound for pneumothorax, some folks will call adding the lung views an extended FAST exam or the EFAST exam. If you've ever heard me talk about the FAST exam, you know my opinion is you're either doing a complete FAST exam or an incomplete FAST exam. The complete FAST exam includes anterior chest fields to look for pneumothorax. And there are a lot of reasons for this. We know that ultrasound is more sensitive. There's lots of good data that ultrasound is more sensitive than the flat AP chest x-ray that we get in trauma patients, and it decreases our time to diagnosis and treatment. Now, people will make the statement, well, what do I do with that information? And the answer to that is you be a physician. You use your clinical judgment along with the ultrasound information to make decisions. And it's pretty straightforward. You have a trauma patient in front of you. You look for a pneumothorax. If you don't see a pneumothorax, please do not place a chest tube. Pretty straightforward, right? Everybody gets that. And consider further workup if needed. Now, you have a trauma patient in front of you. You look for pneumothorax with ultrasound, and you see one. Then you have a decision to make. And basically it's, are they sick? If they have a pneumothorax and they're sick, meaning either they're in shock or they have significant respiratory findings, then you're going to place a chest tube. If they're not in shock and they don't have significant respiratory findings, you can wait. You can know that information is there, use that information, keep an eye on the patient, do the rest of your workup, and then maybe you need a CT scan or an upright chest x-ray, or maybe you want to do a more comprehensive ultrasound. There's lots of different things to do. So it's really no pneumothorax, no chest tube. Yes, pneumothorax, how sick is the patient, chest tube or not. Does that make sense? I hope that helps with the question of, just because I see a pneumo in a trauma patient, what do I do with it? The answer is clinical judgment along with ultrasound. Ultrasound has no brain. We have to use our own. All right, let's go through a little bit of just fast findings. Again, we'll talk about technique and normal anatomy mostly when we practice. Some of the findings that we're going to look for and how to find them. So pericardial effusion, most of the time we'll hopefully see this in a subcostal or a subxiphoid window, but we may be looking in the peristernal window. It's really going to be fluid wrapping all the way around the heart. And it's important to recognize that in an acute setting, it doesn't have to be large to cause signs of shock. So let's look at it in a moving image. So here we see the heart beating, we see fluid all the way around. It should be circumferential, but if you see it in one spot, kind of track your eyes carefully and look and see if you see some of it on the other side. If you don't see it circumferential and the patient looks okay and the heart otherwise looks like it's beating okay, maybe you're just seeing a fat pad or a little bit of trace normal fluid that is sometimes visible. But if you see it wrapping all the way around the heart, then it's probably a real effusion. Now I want to point out that a lot of the examples we show black fluid. But remember, in trauma, the fluid is from blood and bleeding. And blood clots. And when blood clots, it doesn't always look black. It can look more gray. So this is an example of hemothorax. We see some liquid blood that's black wrapping around. But all this gray stuff around the heart is clotted blood that's accumulating around the cardiac sac. So remember not to train your eyes just to look for black stuff to represent fluid. Complex fluid that's infected and proteinaceous can look gray, and blood during its different phases of clotting can also look gray. So blood in trauma may sometimes look gray. Don't miss that. In this example, again, we see liquid blood, this black stuff wrapping all the way around the heart, but there's gray stuff mixed in here too. Some of this here and some of this back here. This is a hemopericardium with different stages of clotting. So don't miss blood just because it doesn't look black. We'll see examples of that in the abdomen and the chest as well. So that's hemopericardium. Fluid is not always black. Next, I like to start on the sides and identify the diaphragms and then work our way down the abdomen. So when we identify the diaphragms, we'll see a diaphragm here, and this is fluid in the chest. We see spine sign posterior. So if the spine extends above the diaphragm, then we know there's something wrong in the chest. In this case, it's fluid in setting of trauma, probably blood. Now, does that mean the patient needs a chest tube? No. This is information. We incorporate it with the rest of the clinical picture. Same thing on the other side. We see a diaphragm here. Remember, head's up here. This is fluid in the chest, and this is some of the lung that's compressed inside that fluid. But this is hemothorax in the setting of trauma. Now remember, this is black fluid in this case, but sometimes it may look gray. And then the pictures we all kind of have seen over and over, fluid in Morrison's pouch. So diaphragm, liver, kidney, and here's Morson's pouch view. This is the one you'll probably see on your boards. Just another example here of some fluid in Morson's pouch. Sometimes it's super obvious, sometimes it's a little subtle, but here's an example. Some other more subtle examples. So I don't want to show you the obvious ones. I want you to see the more subtle ones and be able to pick those up. Little stripe of fluid. And remember, when we do the FATS exam, we're not just taking a single picture. We're identifying our areas of interest, and we're fanning through these areas to examine them completely. Not single pictures, examinations with ultrasound. Another example, subtle fluid just between the liver and the kidney, Morson's pouch. Again, not obvious. And then remember paracolic gutters. Paracolic gutters are actually more sensitive areas to identify hemoperitoneum and trauma than Morson's pouch. So you just slide below the kidney, fan toward the ceiling, and you'll see the bowel, which is kind of outlined with white, and then this is fluid. It'll look like it's pushing down on the bowel. Here we see bowel. We can see where the haustra indent in the large intestine, and then this is fluid in that space. Okay, so this is fluid in the paracolic gutters. On each side of the abdomen, you start from above the diaphragm and work your way all the way down into the paracolic gutters, looking for fluid in the chest and hemoperitoneum. That's what we're looking for. You may do the exact same thing in a patient where you suspect ectopic pregnancy. Just some more examples. So we can see the lower pole of the kidney here, and we actually see the fluid kind of stops right at that lower pole. So if we didn't include the paracolic gutter, we might miss this fluid. So this is fluid in the paracolic gutter here. Here we see the bowel kind of outlined, and we see fluid in the paracolic gutter over here. So keep those in mind. Potential space that if you don't look, you will miss fluid in the abdomen. Remember, on the left side, the splenorenal ligament prevents a lot of fluid from accumulating between the spleen and the kidney. So very important to find the diaphragm on the left side. We're going to see fluid between the diaphragm and the spleen when it's going to be here, so it kind of wraps all around. Again, here we see that little, these are subtle. We see a little bit of fluid wrapping around the spleen here, and then we just follow and look all the way down, and good chance when you get down to the paracolic gutter on this left side, you're going to see more fluid there as well. Now the pelvis is a little different from male to female. We're going to find the bladder, we fan from the patient's feet all the way up to the patient's head, and we examine carefully to look for fluid around the bladder. Most examples you'll see in textbooks, and in a lot of my images you'll see it posterior to the bladder, but it can wrap all the way around the bladder depending on where your slice is at the time. But in females, it's very important to try to identify the uterus in females and look for fluid behind the uterus, because that's where the fluid accumulates in female patients, in that pouch of Douglas or the recto-uterine pouch. So don't just find the bladder in the female patient, try to identify the uterus as well and look behind it, because that's where fluid's going to accumulate. So just some more examples. And you'll notice the difference a sweep makes. So in this case, if we just got this view, we'd say, oh, look at that, it looks normal. It's negative. But as we continue the sweep through the bladder, we see fluid all around and separate from the bladder. And this one's a pretty easy example. We see the bladder and then we see the fluid behind it. That's kind of your textbook case. But all of these examinations are complete examinations, not just a single picture and moving on. More examples of pelvic fluid. And in this case, we actually see fluid. It looks like it's sitting on top. So it doesn't always go posteriorly like you see it in most textbooks. Just look at the bladder and look for fluid anywhere around it or anywhere in the pelvis itself. And you'll notice free peritoneal fluid often takes on sharp points because it just fills any available space, and it doesn't usually have a completely rounded appearance. So in the female pelvis, again, here's a singular picture. We see bladder. This is we're not sure what that is, but we always examine completely, and we want to identify the uterus. So in that same patient, we see kind of higher behind the uterus. Here's the uterus here. Here's all that free fluid in the pouch of Douglas. So find the uterus in the female patient. Look for fluid behind there. Just some other things that you'll maybe notice as you're examining these patients. So this is the patient's left side. So here's their kidney. Now, who thinks this looks like a normal spleen? Nobody, right? The spleen is normally about the same size as the kidney, so if it's bigger than the kidney, it's too big. And this spleen is all heterogeneous, has a lot of different shades of gray and black and white. So this is a trashed spleen that's been significantly injured in trauma, and some of this is probably clot and hematoma wrapped around it. So this is an injured spleen. If you see this in a trauma patient, you know that they've got a significant spleen injury. And then pointing out over here, this is somewhere around the bladder, is like we talked about in the hemopericardium example, is blood is not always black. So you can see some of this is black wrapping around, but a lot of this is gray, partially clotted blood. And just, again, important example that blood anywhere in the body is not always black, free fluid. When it starts to clot, it starts to look gray. Don't miss it because you were only looking for black. So that's really the FAST exam. You're going to use it in your unstable patients to help you diagnose pneumothorax and decide with the whole clinical picture whether they need a chest tube or not. Hemopericardium, whether you're going to do pericardiocentesis or open the chest. Hemoperitoneum to decide if they're going to get XLAP. And blood in the chest to decide is that a source of bleeding and do they need a chest tube or do they need thoracotomy. Now we're going to look at some parenchymal injuries. Now remember, you can't rule these out with the FAST exam, but you may rule them in. You may gather information that helps you take next steps for further imaging or management depending on, again, your setting, your resources, and what you have in front of you. Like I said, cannot exclude them, may help you find things early and help localize injuries. And again, depending on your setting or where you're working, it may help you decide who goes for imaging next, who gets transferred, what resources do they need for transfer, is it someone that needs to fly or do they need to go up at ground, those kind of things. So the first one is lung injury. So we see in both of these examples, we see B lines. So here's a bunch of B lines. Here's multiple B lines that are all confluent. Remember, B lines just represent interstitial fluid. And if you see this in the setting of trauma, then that fluid is probably blood from a pulmonary contusion. So this is what lung injury may look like. And if you see a patient who comes in after trauma and they're kind of having breathing difficulty and they're hypoxic, but they have lung sliding, so there's no pneumothorax, but we see the signs of lung injury, then the lung contusion is probably the etiology for the respiratory distress. Chest tube is not going to fix that. And then this one, again, you would never rule this out with a FAST exam, but we can see here this devascularized black area in the kidney, and then if we light it up with color, we see there's no color within it. There's some artifact here and there, but we watch color kind of wrap around it because it's a devascularized area of injury. This is a renal hematoma. And in this particular case, this was somebody who had just kind of fallen from standing off of a skateboard, had some mild flank pain, didn't really look that impressive, but the ultrasound led us to realize they had a more severe injury than we suspected, and we're able to image them further and manage them appropriately with some help from the FAST exam. Here's another example of a spleen that as you fan through it, you notice it changes echogenicity. It gets brighter white in some areas, and it's not all nice and homogeneous and gray as it should be. We see some areas of black, some areas of white. This is a similar example. We even see some little darker areas streaking through here. So this is a sign of a spleen injury, and we should probably, if that's not already known or suspected, we definitely want to image that further. We can also, once we've established a diagnosis, maybe we can follow it with ultrasound later instead of repeating CT scans if they're having continuing or recurrent abdominal pain or something like that. Just more examples of spleen injury. Here we see the spleen is just too big, and there we see a little bit of free fluid down towards the edge of the spleen. So here's the kidney. Remember, the spleen should not be bigger than the kidney. The spleen's bigger than the kidney. It's probably got something wrong with it. It's injured. We see some different textures and echogenicities. We see free fluid here. We see how large it is. This is in the setting of trauma. This is an injured spleen. And here, if we want to measure it, I don't like to use calipers. I like to train my eyeballs. But we see kidney. This spleen is way bigger than that kidney. There's even an edge of free fluid around here, so we can know kind of in minutes or seconds really that this patient has a spleen injury. Just more examples of heterogeneity. Irregular borders also is a clue. Remember, the spleen should have nice smooth borders and edges all around it, and it should all be the same shade of gray. Here we see kind of rougher borders and we see different shades of gray mixed in. Same thing over here. So these are signs of spleen injury. They help you localize this, what's going on, more quickly at the bedside than if you hadn't looked. And this may help you decide, this patient is next in line for CT scan. This patient needs the nurse to go with them. This patient needs to have blood transported with them. And this other patient can go down the line. So that's how, even in these stable patients, some of these things can help you. We've got a similar thing in the liver here. Liver should all be one kind of color. smooth borders and the same echogenicity, but here we see this kind of brighter white irregular area in the liver. Now this, in the setting of trauma, you would assume this is an injury. There are other things that can look like this, tumors, masses, but in the setting of trauma, you're going to assume that this is an injury and recognize that even if this patient is stable, even if they told you they just fell from standing, maybe there's more going on and you need to work them up further. So there are some things, and we'll look at these a little bit in our normal patients when we practice, some things that can cause false positives. On the heart, you can have a fat pad that can sometimes confuse folks for a pericardial effusion. On the right side of the abdomen, the inferior vena cava, the gallbladder, the portal vein can all kind of look like free fluid, so we want to just be mindful and take a look at those and what they look like. Usually if you notice a nice rounded shape, that's a clue that it's not free fluid. Sometimes there can be a little perinephric fat that can mimic a positive fluid in Morrison's pouch. We'll probably see some examples of that. The stomach is a big one on the left side, so recognize what the stomach looks like. We'll look at that as well. In the pelvis, the seminal vesicles can sometimes look like free fluid posterior to the bladder, so we'll watch out for that. Females that are childbearing age, or even pediatric males and females, sometimes can have some small amounts of free fluid in the pelvis. Especially women of childbearing age, physiologic free fluid in the pelvis is pretty normal. So seeing that, one, is a testament that you're doing good scanning and recognizing it, but then when you see that in the setting of trauma, then you're going to have a decision to make and decide, do you think that's just normal physiologic fluid, or is it pathologic bleeding into the abdomen? There can be bladder diverticuli, and kind of anywhere around the kidneys you can see kind of bowel filled with fluid. There's pending diarrhea, or cysts on the kidneys or things like that can all kind of mimic free fluid. So just be mindful of what you're looking at. You look at the shape of it, and if you're not sure about it, kind of look a little harder and see if you can decide, is this truly free fluid or is it a mimic or something else? Now, our decision making can be pretty straightforward, and mostly we're going to talk about blunt trauma, although in penetrating trauma, the FAST exam, especially the cardiac views, can be super critical. Let's talk about blunt trauma first. So the FAST exam, they've got blunt trauma. You do the FAST exam as part of your workup, and let's say it's positive. If it's positive and they're stable, then they get priority to go to CT and get nursing resources, blood resources if you have them available. Or you may just say, they've got a positive FAST, even though they're stable now, I need to fly them to the closest trauma center, and I'm not going to wait for other information before I make that decision. Now, if they're not stable, then you're probably going to say, and they've got a positive FAST exam, you probably have something actionable, whether they need a chest tube, thoracotomy, maybe pericardiocentesis, depending on your setting, or a laparotomy. So these are all things you may be thinking about immediately in the unstable patient with a positive FAST exam. Now, they've got trauma, and you do a FAST, and it's negative. Well, if it's negative and they're unstable, then resuscitate, think about other sources, and then repeat it in 10 or 15 minutes after resuscitation, because maybe more blood is accumulated in the abdomen, or other injuries have accumulated that they'll be able to be more visible in the next 10 or 15 minutes during your resuscitation. If they're stable with a negative FAST exam, then you can kind of use the rest of the clinical picture to decide, do I need a CT or not? If they're high risk, they've got abdominal bruising, a lot of abdominal tenderness, base deficit on their blood gas, something like that, then you're probably going to CT that patient. But if they don't have a lot of high risk findings, then that may be a patient who's a candidate for serial exams, serial H&H, serial FAST, and maybe we can be a little bit more selective with our CT scans and cut down on some of the radiation and low diagnostic yield on low risk stable trauma patients. And there's no perfect number, there's no exact perfect algorithm, there's always going to be clinical judgment to help you decide with that. And I don't have a diagram for it, but let's talk a little bit through the FAST in the penetrating trauma patient. Whether they're stable or not, this can still help you. If they're unstable and you see hemopericardium, then you know quickly that that's probably the source of their injury. And if they lose vital signs, you want to get into the chest quickly and try to address that. And that's probably the biggest decision maker. If they've got penetrating trauma to the abdomen, free fluid in the abdomen increases the likelihood of a bowel or parenchymal injury and increases the case that they just need to go to the operating room. Although depending on their stability and your setting, there's probably a role for CT scan as well. A little more nuance into that topic we're not going to get into. But penetrating trauma, especially to the chest, if they've got fluid around the heart, and that is the biggest target for intervention in the penetrating trauma patient, especially if they lose vital signs in front of you. If they've got penetrating trauma and they're stable, then the FAST exam may help you identify earlier fluid in the abdomen, fluid in the chest, fluid around the heart, and again, just help you tailor your decisions and work through the decision making in that patient with a little more information than you would have just with history and physical alone. So remember the pitfalls, we talked about these. The pneumothorax is not quantified. It's just giving you pretty much a yes or no. You have to use the rest of the clinical picture to help you decide what to do with that. Just because we see blood in the abdomen, we don't know where the bleeding is coming from necessarily. We're not seeing the retroperitoneum terribly well. As always, with all information that we have, we incorporate it into the entire history and physical. We have brains, the ultrasound machine doesn't. The big pearls are just practice, get your routine down, make sure you're being systematic and checking all the major anatomical landmarks that we're going to go through. Make sure you're using good hand skills, your hands up against the patient. Examine each area. It's not a single shot picture and move on. It's an examination of each anatomical area. And then again, if you're resuscitating the patient and the first FAST exam is negative, there sometimes is a saying that a FAST exam is not negative until it's the second FAST exam that's negative. So repeat them as needed during the course of the resuscitation to see if things change. So quick summary on the FAST exam. A good quality FAST exam adds valuable information to your history and physical. It's quick, it's bedside, and doesn't have the radiation costs or delays of CT scan. Makes 4 diagnoses: pneumothorax, hemothorax, hemopericardium, hemoperitoneum. It can help us make immediate treatment decisions in the unstable patient, and these are big deal decisions: chest tubes, intervening on the heart and the chest, or laparotomy. And then in the stable patient, it can help us expedite decisions, choose who needs the most resources right away versus who can wait, and maybe lets us be more selective with our CT scans, reserving them for the higher risk patients who are altered, have significant signs of trauma, severe pain, or other findings. And then the patients who maybe aren't high risk, we can do serial exams, serial fasts, and save that radiation for another